Hey everyone, welcome back to the Deep Dive. We're diving into a topic that's super important for all you future critical care nurses out there.
Hematology.
You got it. And we're not just going to skim the surface.
Oh, no, we're going deep.
Exactly. We're
Yeah.
talking about the stuff that's going to really make a difference when you're out there on the floor, taking care of patients.
Especially when you're facing those tough NCLEX questions.
Totally. So picture this, right? You're fresh out of nursing school.
First shift in the ER.
Yep. Heart's pounding, you're ready to go. And
Ooh.
in comes a patient after a major car accident.
Pale, clammy, weak pulse.
Blood pressure's in the basement. What's going through your head?
Honestly, in that moment, it's all about recognizing those signs of shock.
Shock, right? Because they've lost a lot of blood.
Exactly. Hypovolemic shock.
So what's the first thing you do?
You got to stabilize them fast.
And how do we do that?
We got to stop the bleeding and we got to restore that circulating volume.
So that's where blood transfusions come in.
Yeah, absolutely. Blood transfusions are a lifeline in these situations.
It's not just about replacing the blood they've lost, right?
Nope. It's about restoring the blood's ability to carry oxygen to the vital organs.
Because without enough healthy red blood cells, the body just can't function.
It starts shutting down.
And that's when things can go south really quickly.
Exactly.
This is where knowing your blood components becomes like superpower knowledge.
Oh, yeah. Packed red blood cells, platelets, fresh frozen plasma.
They're like the Avengers of hematology.
Huh. I like that. Each one has its own special mission.
Okay, so break it down, Wes.
All right. So say you've got a patient whose hemoglobin and hematocrit are plummeting.
Not good.
You reach for the PRBCs, the packed red blood cells.
They're like little oxygen tanks, right?
Exactly. They boost the blood's carrying capacity.
Got it. What about when you've got a patient who's bleeding excessively?
Think platelets.
Yeah.
They're like the first responders to a bleeding crisis.
So if you've got a patient with thrombocytopenia, low platelet count,
You might see petechiae, bleeding gums.
and a platelet transfusion can help control that bleeding.
Exactly. Now, fresh frozen plasma, that's our clotting factor powerhouse.
Okay, when do we use that?
Think bleeding disorders like hemophilia, where the blood just doesn't clot properly.
Or liver disease where they're not making enough clotting factors.
Exactly. It's like having a backup supply of those crucial ingredients.
I'm starting to see how important it is to know which blood product to use in each situation.
Absolutely.
But it's not just about knowing what to use, it's also about knowing what to watch out for.
Transfusion reactions.
Yeah, those can be scary.
They can be serious.
Well-
You need to be on high alert for any signs of trouble.
So let's talk about those transfusion reactions. What are the red flags?
Well, there are different types, each with its own set of signs and symptoms.
Okay, like what?
The most serious one is an anaphylactic reaction.
That sounds terrifying.
It is. You're looking for wheezing hives, a sudden drop in blood pressure?
All happening really quickly after the transfusion starts.
Exactly.
Yeah.
You need to act, fast stop the transfusion, administer epinephrine.
Oxygen to feed fluids the whole 9 yards.
It's a true medical emergency.
Okay, so that's anaphylactic. What about the less severe reactions?
Well, there's the febrile reaction. You might see chills, fever, headache.
In that case, you'd slow down or stop the transfusion.
And give antipyretics as ordered.
So we've got anaphylactic febrile. What else?
There's the hemolytic reaction. This is when the recipient's body attacks the transfused red blood cells.
And that can be life-threatening too, right?
It can be. You might see lower back pain, chills, fever, a rapid heart rate.
What do you do?
Stop the transfusion, maintain urine output, administer oxygen.
So many things to watch for.
That's why vigilant monitoring is key. You're the patient's advocate.
Okay, 3 down anymore.
One more: circulatory overload.
What's that?
It's when the transfusion is given too quickly, overwhelming the system.
So you're looking for signs of fluid overload.
Exactly. Shortness of breath, crackles in the lungs, distended neck veins.
Slow that transfusion way down.
And administer diuretics as ordered.
Wow, just blood transfusions alone are a whole world of knowledge.
It's a lot, but it's all about understanding the principles behind it.
Right, once you get those down, it all starts to make sense.
Exactly.
I'm feeling a lot more confident already. So what's next on our hematology deep dive?
Let's talk about anemia.
Anemia, okay.
It's basically when the body isn't getting enough oxygen because of a lack of healthy red blood cells.
And there are so many different types of anemia.
There are.
Yeah.
The NCLEX loves to test on iron deficiency, sickle cell, and pernicious anemia.
Let's start with iron deficiency anemia. What's that all about?
Imagine a young woman comes in fatigued, pale skin.
Classic signs of anemia.
But here's the thing, she's craving ice.
Craving ice.
It's called pica.
Interesting. Okay, so iron deficiency anemia, what causes it?
Could be blood loss, like heavy periods, or not enough iron in the diet.
Or maybe the body's not absorbing iron properly.
Right. In her case, those heavy periods could be the culprit.
So how do we treat it?
Replenish the body's iron stores, usually through iron supplements.
If it's really severe?
A blood transfusion might be necessary.
Okay, got it. Now, what about sickle cell anemia? That one always sounded scary to me.
It can be serious. It's a genetic condition where the red blood cells are abnormally shaped like sickles.
Sickles,
And these misshapen cells can get stuck in small blood vessels.
causing all sorts of problems.
Excruciating pain, even organ damage.
So it's not just about not having enough red blood cells, it's that they're not working.
Right, exactly.
What if a patient with sickle cell anemia comes into the ER with severe pain?
Say in their chest and abdomen and they're having trouble breathing.
Okay, so we've got pain, we've got respiratory distress,
Pain management is a top priority.
oxygen therapy to help them breathe better.
Absolutely. And you'd want to start IV fluids to prevent further blockage of those blood vessels.
And of course, close monitoring of their vital signs.
Always.
Okay, so I've got iron deficiency, I've got sickle cell. What about pernicious anemia?
This one's interesting because it's all about vitamin B12.
B12.
The body can't absorb it properly.
And B12 is crucial for red blood cell production.
Exactly. Now here's a key point for the NCLEX.
Hit me with it.
Pernicious anemia often comes with neurological symptoms.
Really? Like what?
Tingling numbness in the extremities.
So it's not just about feeling tired and weak.
Nope. Think about an older adult coming in with fatigue, shortness of breath,
Okay.
and they're complaining of tingling and numbness in their hands and feet.
And their B12 level is super low.
Bingo. Pernicious anemia.
So they would need B12 injections.
Lifelong injections to replace what their body can't absorb.
We've covered so much ground already.
We have. But hey, you're doing great.
Thanks. It's a lot to take in, but it's starting to click.
That's what we like to hear.
So what's next?
Let's take a look at some conditions that can mess with the clotting system.
Like what?
Hemophilia and thrombocytopenia.
Okay, you know what though? I need a water break.
Sure. Let's take a quick break and we'll come back and tackle those bleeding disorders. Okay, so let's dive into those bleeding disorders. Hemophilia and thrombocytopenia.
All right, hit me with it.
Huh.
What's hemophilia all about?
Well, it's a genetic condition where the blood just doesn't clot properly.
Because they're missing certain clotting factors.
Exactly. Imagine a young boy who bruises really easily.
And bleeds for a long time after even a small cut.
That could be a sign of hemophilia. And for the NCLEX, you need to know.
Tell me.
There are different types of hemophilia depending on which clotting factor is missing.
Oh, right. Like hemophilia A and B.
You got it. Hemophilia A is the most common one. It's a deficiency in factor VIII.
And hemophilia B is a deficiency in...
Factor IX.
Okay, different types.
Yeah.
But the same basic problem clotting is messed up.
Exactly. And as a nurse, you need to think about safety first.
Right, because even a minor injury could be a big deal for someone with hemophilia.
Exactly. We need to teach them how to prevent injuries.
And how to control bleeding when it does happen.
Right. So things like avoiding contact sports.
Makes sense. What about medications? Are there any they should avoid?
Oh, yeah, definitely. Things like aspirin and ibuprofen.
Because those can make bleeding worse.
Exactly. They can interfere with platelet function.
So it's all about minimizing risks.
And being prepared to manage those bleeding episodes.
And sometimes they might need regular infusions of that missing clotting factor.
Right. Especially in severe cases to prevent spontaneous bleeding.
Okay, now let's switch gears and talk about thrombocytopenia.
Thrombocytopenia, it literally means low platelet count.
And platelets are essential for clotting.
Right. So when the count gets too low...
The risk of bleeding goes way up.
Exactly. We're not just talking about a few extra bruises here.
This is serious stuff.
Think about a patient who develops those tiny red or purple spots on their skin.
Petechiae.
Yep. Or they start bleeding from their gums or nose for no reason.
Those are red flags.
Big time. And there are a lot of different things that can cause low platelet count.
Like what?
Infections, autoimmune disorders, certain medications, even cancers.
So you got to figure out the underlying cause to treat it effectively.
Exactly.
What about treatment for thrombocytopenia? Is it similar to hemophilia?
It really depends on the cause and how severe it is.
Sometimes treating the underlying condition might be enough.
Right. But other times, a platelet transfusion might be necessary.
And just like with any blood transfusion, we need to be watching for reactions.
Always. Vigilance is key in hematology. You got to be constantly assessing, monitoring, anticipating.
It's like being a detective.
In a way it is. You got to put all the pieces together.
All right, so we've got hemophilia, thrombocytopenia.
Two big players in the world of bleeding disorders.
Definitely complex stuff.
They are, but by understanding what's going on and what can go wrong, you'll be ready to provide great care.
Okay, let's shift gears again. I know this one can be intimidating for nursing students.
Blood cancers.
Yeah, those always seem so complicated.
I get it, but we'll break it down, don't worry.
Okay, I'm ready. Let's start with leukemia. What's the deal with that one?
Think of it like a factory gone rogue,
A rogue factory.
producing way too many abnormal white blood cells.
Okay, so it's like an overproduction problem.
Exactly. And these abnormal cells crowd out the healthy ones in the bone marrow.
So it's not just the white blood cells that are affected,
Nope. It throws off the whole blood cell production system.
leading to all sorts of problems.
Fatigue, weakness, increased risk of infections, bleeding. You name it.
Okay, now what about lymphoma? How's that different?
Lymphoma is a cancer that affects the lymphatic system, part of the immune system.
Okay, so leukemia is in the bone marrow and lymphoma is in the lymphatic system.
You got it. And lymphoma often shows up as painless swollen lymph nodes.
Interesting. So are there any symptoms that overlap between the two?
Oh yeah, for sure. Both leukemia and lymphoma can cause fatigue, weakness, weight loss.
So how do you tell them apart?
Well, one key difference is the presence of Reed-Sternberg cells.
Reed-Sternberg cells.
Yep, they're a hallmark of Hodgkin's lymphoma.
So you don't see them in non-Hodgkin's lymphoma or leukemia.
Exactly. And you also got to consider the patient's age, their specific symptoms, the results of blood tests, biopsies.
Speaking of biopsies, what kind of tests are used to diagnose blood cancers?
A bone marrow biopsy is a big one. It lets doctors see what's going on in the bone marrow.
Looking for those abnormal cells.
Right. And we also use a bunch of different blood tests.
Blood count, blood smear, genetic testing.
But the whole works. It's like a detective case.
So once you've got the diagnosis, then what?
Then it's all about treatment. Chemotherapy, radiation therapy, targeted therapy, even stem cell transplantation.
Wow, those are some heavy-duty treatments.
They are. But it's amazing how far we've come in managing these diseases.
It really is. And as nurses, we need to understand not just the science, but also the human side of it.
Absolutely. How to care for these patients.
So what are some key things to keep in mind when caring for someone with a blood cancer?
Well, first of all, they're going through a lot emotionally.
Fear, anxiety? Hope it's a roller coaster.
It is. So providing emotional support and compassionate care is huge.
Just being there for them.
Exactly. And then there's the physical side of things, managing potential complications.
Like infections and bleeding.
Right. Their immune systems are often weakened either from the cancer itself or the treatments.
So infection control is super important.
Absolutely. Meticulous hand hygiene monitoring for any signs of infection.
And then there are the side effects of the treatments to think about.
Nausea, vomiting, hair loss, fatigue. It's a lot to manage.
So it's a holistic approach.
It really is. You're caring for the whole person.
Okay, we talked about a lot of different hematology topics, but there's one more I want to touch on.
What's up?
Disseminated intravascular coagulation. DIC.
Ah, DIC. It's a tricky one.
It sounds terrifying. Honestly,
It can be. It's basically a clotting paradox.
a paradox.
What do you mean? The body is both clotting and bleeding at the same time.
How is that even possible?
Well, the clotting system gets totally out of whack.
Okay.
You get widespread clotting in the small blood vessels, which uses up all the clotting factors.
Then you start bleeding because there's nothing left to stop it.
Exactly. It's like a runaway train going from one extreme to the other.
What are the signs that this is happening?
DIC can show up in a lot of different ways. Bleeding from multiple sites, petechiae and purpura, signs of organ damage from the clotting.
So you got to be really suspicious if a patient starts having unexplained bleeding or clotting.
Especially if they have a condition that puts them at risk for DIC, like sepsis or trauma.
Okay, so early recognition is key. What about treatment? How do you manage this mess?
The first thing is to treat the underlying cause, whatever triggered the DIC.
Right, so if it's sepsis, you treat the sepsis.
Exactly. And then you got to support the clotting system while also managing the bleeding.
That sounds like a tough balancing act.
It is. You might need to give transfusions of platelets, fresh, frozen plasma cryoprecipitate.
And sometimes even heparin to prevent more clots from forming.
But you got to be careful with heparin. It's a delicate balance.
So it's like walking a tightrope.
Exactly. And that's why understanding DIC is so important for critical care nurses.
I'm starting to see that a lot of hematology is about finding that balance.
It really is. It's about understanding how all the pieces fit together.
Okay, I think we've covered a ton of ground today.
Yeah.
From blood transfusions to anemia to bleeding disorders to blood cancers to DIC. It's a lot.
It is. But hey, you're doing great. You're asking all the right questions.
Thanks. I'm starting to feel more confident about hematology.
That's what we like to hear. Remember, it's a journey.
One step at a time.
Exactly. Now, what do you say we take a break and then come back and talk about another important topic?
Okay, what's next on the agenda?
Let's explore the world of HIV and AIDS.
Okay, we're back and ready to tackle HIV and AIDS. It's a big topic, but it feels like one every nurse needs to know inside and out.
Absolutely. It's a complex issue, but we can break it down into manageable pieces.
Okay, sounds good. Where do we even start?
Let's start with the basics. HIV, the human immunodeficiency virus, attacks the body's immune system.
Specifically those CD4 plus T cells, right?
You got it. Those are the cells that are like the conductors of the immune orchestra. They
Right.
coordinate the fight against infections.
So HIV weakens the immune system, leaving it vulnerable to all kinds of infections that wouldn't normally be a problem.
We call them opportunistic infections. They take advantage of the weakened immune system.
And if HIV isn't treated, it can progress to AIDS.
Acquired immunodeficiency syndrome. That's the most advanced stage of the infection, where the immune system is severely compromised.
And that's when those opportunistic infections can become really dangerous.
Life-threatening, even.
Okay, so understanding the different stages of HIV is crucial.
Absolutely. For providing the best care, and of course for acing those NCLEX questions.
So walk us through those stages. What do we need to know?
Okay, so the first stage is called acute HIV infection. It usually happens within a few weeks of being exposed to the virus.
And what happens during this stage?
Well, people might have flu-like symptoms, fever, fatigue, sore throat, swollen lymph nodes.
So it could be easy to miss or mistake for something else.
Exactly, it's like a stealth attack. And here's the tricky part.
What's that?
During this acute stage, the standard HIV antibody tests might come back negative.
Wait, seriously? You could have HIV and not even know it.
It's possible. That's why understanding the window period is so important.
The window period.
That's the time between when you're infected and when a test can accurately detect it.
Okay, so what happens after that acute infection stage?
The next stage is called clinical latency or chronic HIV infection. The virus is still there, but it's replicating at a much slower rate.
So people might not have any symptoms at all.
Right, or they might have mild symptoms that come and go.
So you could be living with HIV for years without realizing it.
Exactly. That's why regular HIV testing is so important.
Early detection is key.
It can make a huge difference in how well you manage the disease and whether it progresses to AIDS.
Okay, let's talk about AIDS then. What defines that stage?
AIDS is diagnosed when the person's CD4 plus T cell count drops below a certain level.
So their immune system is severely weakened.
Right, and they become much more vulnerable to those opportunistic infections.
Ones a healthy immune system would normally fight off.
Exactly. And it can be much harder to treat those infections when the immune system is so weak.
So let's shift gears and talk about treatment. What are the main therapies for HIV these days?
The big one is antiretroviral therapy, or ART. These medications work by suppressing the replication of the virus.
So they keep the virus from multiplying.
Exactly.
Good.
And that gives the immune system a chance to recover, and it prevents the progression to AIDS.
So it's not a cure, but it can control the virus.
Exactly. ART can reduce the amount of virus in the body to the point where it's virtually undetectable.
So people with HIV can live long and healthy lives if they're on effective treatment.
And they have a much lower risk of transmitting the virus to others.
That's incredible. It really highlights the importance of early detection and treatment.
Absolutely.
Now, for our nursing students out there, what are some of the key things to keep in mind when caring for someone with HIV or AIDS?
Well, first and foremost, compassionate, non-judgmental care is essential.
Right. These patients often face so much stigma.
They do. So creating a safe and supportive environment is paramount.
Building trust is essential.
Absolutely.
What about infection control? Any specific precautions we need to be aware of?
Standard precautions are usually enough for most things. But you got to be extra careful anytime there's a chance of contact with blood or body fluids.
Even though effective RT can reduce the risk of transmission.
Right. It's still crucial to take all the necessary precautions.
Makes sense. What about patient education? What do we need to teach these patients?
Well, medication adherence is huge. They need to understand the importance of taking their medications exactly as prescribed.
Every single day.
Exactly. And we also talk about healthy lifestyle choices, getting enough sleep, eating a balanced diet, managing stress.
All those things that can support a healthy immune system.
Right. And of course, regular medical follow-up is essential.
To monitor their condition and adjust their treatment plan as needed.
You got it.
It sounds like caring for patients with HIV and AIDS really does require a holistic approach.
It does. You're addressing their physical health, their emotional well-being, their social needs.
It's about the whole person.
Exactly.
Before we move on from HIV and AIDS, I want to touch on prevention. What can we do to stop the spread of this virus?
Education is key. We need to talk about safe sex practices, the importance of regular HIV testing, and the availability of pre-exposure prophylaxis.
Right. Pre-PP has been a game changer for people who are at higher risk of infection.
It really has. We've come a long way in understanding and managing HIV.
We really have.
And for nursing students, it's important to remember that HIV and AIDS aren't just medical conditions. There's social and ethical issues, too.
That's an important point.
We need to approach care with empathy and understanding.
Okay, I think we've covered the essentials of HIV and AIDS. Let's move on to another fundamental concept in hematology.
Clotting.
Clotting, right? That intricate dance between platelets, clotting factors, and a whole cascade of events.
That either keeps us from bleeding out or causes serious problems if it goes wrong.
And there are so many lab values we need to understand when it comes to clotting APTT D-dimer. They always seem to trip me up.
I know this can be confusing, but we can break some down.
Okay, I'm ready.
So think of PT prothrombin time as measuring the extrinsic pathway of the clotting cascade.
The extrinsic pathway.
It's the pathway that gets activated when there's tissue damage, like a cut or a scrape.
So PT tells us how quickly the body responds to external injuries.
Exactly. And then you've got APT-activated partial thromboplastin time.
Which measures the intrinsic pathway.
Right. This pathway is activated by things inside the blood itself, even without an external injury.
So two different pathways, but they both lead to a clot.
Exactly. And these tests help us see how well those pathways are working and whether there might be a deficiency in any of the clotting factors.
So if someone's PT or APTT is prolonged, that means their blood is taking longer to clot.
Which could put them at risk for bleeding.
And that's where medications like heparin and warfarin come in.
Right. They can prolong clotting times, which can be helpful for preventing blood clots, but it also means we need to monitor those patients closely.
Okay, that makes sense.
Yeah.
Now, what about D-dimer?
D-dimer is a marker of fibrin breakdown.
Fibrin.
It's that protein that forms the meshwork of a blood clot. So when a clot breaks down, D-dimer is released into the blood.
So if someone's D-dimer is elevated, it can mean they've had some clotting going on.
Exactly. It's a helpful clue for conditions like DVT or PE.
Deep vein thrombosis and pulmonary embolism.
Where clots can form in the legs or lungs and then travel to other parts of the body.
So we're not just looking at these clotting studies in isolation. We're thinking about the big picture.
Absolutely. We're connecting the dots between those lab values, the patient's clinical presentation, and their overall health.
All right, we have covered so much ground in this hematology deep dive. I'm feeling a little overwhelmed, but in a good way.
Hematology is a lot to take in, but it's also incredibly fascinating, and you're asking all the right questions.
Thanks. So as we wrap up this episode, what's the one key takeaway you want our listeners to remember?
Hematology is all about balance. The balance between oxygenation, perfusion, and clotting. When one of those systems is out of whack, it can affect the whole body.
And as nurses, we need to be able to spot those imbalances and intervene.
Exactly. We're the ones at the bedside advocating for our patients.
Yeah. Well said. For all of you listening who are gearing up for the NCLEX, remember this. The journey to becoming a nurse is a marathon, not a sprint.
Keep learning, keep practicing, and never be afraid to ask for help.
Knowledge is power. The more you understand about hematology, the better prepared you'll be to care for your patients.
Couldn't have said it better myself.
And as always, thanks for joining us on The Deep Dive. We'll catch you next time for another deep dive into the world of nursing.
See you then.